Hi everyone, I'm a new Kathiresan fertility physician and Dr. Mom and here to educate on fertility. There are different types of frozen embryo transfer protocols. In this video, we'll be specifically talking about the natural cycle frozen embryo transfer protocol. So let's start that discussion now. Proceeding with a natural cycle frozen embryo transfer, we want to make sure a few things are addressed. The first is we want to make sure the goals from the IVF cycle were met in terms of number of embryos and the sex of the embryos, in terms of meeting the family building goals for that particular couple. Assuming that's the case, the other things we also want to make sure that are taken care of are the uterine cavity evaluation. That can be done either with a saline ultrasound, a FemView, or a hysteroscopy, but we want to make sure the uterus is nice and normal before we put the embryo back in. The last thing is what's called a mock transfer or trial transfer. It is basically a practice run at putting the embryo back in because we just don't want to run into any surprise on the real day when we're performing the embryo transfer. After all of these things have been taken care of, then we're ready to proceed. The premise of the natural cycle frozen embryo transfer protocol is that we are simply monitoring the patient as she would cycle normally without any medication or very minimal medication. So we'll do a baseline ultrasound, we'll watch the follicle grow, and then we would, once the follicle reaches the right size, perhaps trigger ovulation or have the patient call with ovulation predictor kits. And then we will time specifically when the transfer is based on either when ovulation was triggered or when the ovulation predictor kit was positive. So the advantages and disadvantages to this type of protocol. So some of the advantages are that the woman is growing a follicle, so she'll be making her own hormones, estrogen and progesterone, so we can get away with less medication, meaning no IM shots, compared to the medicated frozen embryo transfer protocol. Some of the disadvantages is that there is less flexibility in terms of scheduling the transfer. So for example, if the woman is wanting to schedule the transfer on a particular day, it's hard to guarantee that. It's going to be dependent on the size of the follicle when the follicle ovulates. So there are some limitations scheduling wise that way. Also, we want to make sure the lining gets to the right thickness. And if we're not giving medications, if the woman's ready to ovulate and the thickness is not appropriate, we may not be able to proceed with the transfer. So that's another disadvantage. If a woman does not have regular cycles, this type of protocol may not be best for them, but please discuss with your healthcare physician all the protocols and what would be best for your particular case. Pregnancy rates are similar amongst all the different protocols, so there's not a right or wrong answer necessarily, but again, please discuss it with your healthcare provider. Now we'll go over the steps of the natural cycle frozen embryo transfer protocol. The first steps of the natural cycle frozen embryo transfer protocol is that we will have the patient call with their period, and then we'll bring them in for baseline ultrasound and blood work to make sure everything looks good to start. And then we would bring them in potentially a week later, around cycle day 10 to 12, do another ultrasound and blood work assessment. And we're looking for the follicle to be a particular size, and also we're looking specifically at the lining. The two things we're looking at with the lining are going to be a certain thickness of the lining, and that can vary clinic to clinic in terms of the threshold, but generally around 7 millimeters in size. And we're also looking for a particular characteristic of the lining, which is this trilaminar 3-line appearance. Once we achieve the follicle size and then the thickness and characteristic of the lining, then we'll have the patient trigger ovulation, and then we'll plan the embryo transfer to be approximately 1 week after the trigger. The patients will also start estrogen and progesterone after the trigger. Alternatively, another way to do a natural cycle frozen embryo transfer protocol would be to have the patient call with their period. We bring them in for baseline ultrasound and blood work and make sure everything looks good to start, and then have the patient call when they experience the LH surge on their ovulation predictor kit. Then they'll come in the following day, we'll do ultrasound and blood work, confirming that the patient ovulated and that the lining is the appropriate thickness, and then we'll plan the transfer accordingly, as well as start the estrogen and progesterone accordingly. This leads me to the embryo transfer. The embryo will be thawed that morning, and there's approximately a 95% survival rate for the embryo to survive the thaw. The next concern is how many embryos do we put back in? Nowadays, we do a lot of genetic testing, and so this has dramatically increased our success rates that we usually will recommend putting one embryo back in at a time. But every patient's clinical history is different, so please discuss this with your healthcare provider. The next thing is how we actually do the procedure. I have done a video on the embryo transfer, and I will link it here, and also preparation for the embryo transfer. But to briefly summarize, you'll come in that day with a full bladder. Some clinics don't use any anesthesia, some use oral Valium, either is really okay. And we will put a speculum in, perform a gentle lavage, and then advance a soft catheter into the cervix and in the uterus, and then deposit the embryo near the top of the uterus, and then we'll gently remove the catheter. Patients will then rest for about 20 to 30 minutes before they'll get up and leave the clinic that day. The last step is checking the pregnancy test. We usually check the pregnancy test anywhere from 9 to 14 days after the embryo transfer. If the pregnancy test is positive, we'll repeat it 48 hours later, and we're looking for an appropriate rise in that beta HCG. If we see that appropriate rise, then we are reassured and we'll go ahead and schedule the first OB ultrasound around 6 weeks of gestation, which is approximately 2 weeks from when we check that initial beta HCG. Patients will also continue the medication. In this scenario, the patient did ovulate and does have a corpus luteum making estrogen and progesterone. So typically we stop the medications a little earlier in this type of protocol compared to the medicated frozen embryo transfer protocol. And that can vary clinic to clinic, but it can go to approximately 8 weeks of gestation. If the beta HCG rise is not appropriate, then we're concerned if the pregnancy might be a miscarriage or might be an ectopic pregnancy. So we will keep a closer eye on these patients and bring them in for blood work and ultrasound earlier. The last scenario would be if the beta HCG was negative. If this were to be the case, we'll have the patient stop the medication, and then we'll schedule a follow-up visit where we'll go over next steps from there. That is it for this video. Please remember that every patient is different, so please discuss your own clinical history with your provider to determine which protocol might be best for you. I hope you found this video helpful. If you did, I hope you'll give the video a like. Don't forget to subscribe down below. If you have comments or questions, you can leave them for me there also. Thank you again so much for watching, and see you in the next video.